This is a presentation on idiopathic inflammatory myopathies. The learning objectives are as outlined. Idiopathic inflammatory myopathies are a heterogeneous group of disorders that are predominantly immune-mediated and cause muscle weakness. They include polymyositis, dermatomyositis, inclusion body myositis, immune-mediated necrotizing myopathy, cancel-associated myositis, and overlap myositis. Idiopathic inflammatory myopathies have a worldwide incidence of approximately 5 to 10 per 100,000. This condition affects both adults and children. Adults between 40 to 50 years of age and children between 5 to 10 years of age are commonly affected. Idiopathic inflammatory myopathies is also more common in women than men, with a ratio of 2 to 3:1. Idiopathic inflammatory myopathies is also associated with malignancies, especially in middle-aged and elderly patients with dermatomyositis. 15% of dermatomyositis patients have malignancy-associated disease. In our Asian population, particularly nasopharyngeal carcinoma. Other malignancies include ovarian, gastrointestinal, lung, breast cancer, and lymphoma. The pathogenesis of polymyositis, dermatomyositis, and inclusion body myositis are as described. In polymyositis, CD8 plus T cells clonally expand in situ and invade MHC1 expressing muscle fibers. In dermatomyositis, there is complement-mediated microangiopathy with destruction of capillaries and inflammatory cell stress at perivascular regions. Inclusion body myositis is similar to polymyositis, with vacuolization and accumulation of stressor and amyloid-related molecules. The clinical features include gradual onset symmetric proximal muscle weakness, i.e. patients may complain of difficulties getting up from a seat, reaching for objects overhead, myalgia, dysphagia, dysphonia, and dyspnea. This slide compares polymyositis versus dermatomyositis. In polymyositis, patients typically present with symmetrical proximal muscle weakness, and muscle biopsy will show distinct histological features. Polymyositis is rare in children. In dermatomyositis, patients may present with dermatologic manifestations such as heliotrope rash, goitron papules, Shaw sign, V sign. Patients may or may not have muscle weakness. Dermatomyositis has distinct histological features on muscle biopsy. This condition can be seen in children. This picture illustrates a heliotrope eruption. There is pink to violaceous erythema of the eyelids, occasionally with associated edema. This picture illustrates goitron papules, which are raised erythematous to violaceous papules or plaques on the extensor surfaces of the metacarpal and interphalangeal joints. This picture illustrates the V sign and Shaw sign, which is a diffused photosensitive erythematous rash over the upper chest and neck in a V-shaped distribution. This picture depicts mechanic hands, which is the roughening and cracking of the skin of the tips and lateral sides of the fingers. It is seen in anti-synthetase syndrome, whereby patients usually also have anti-Jo1 positivity, fever, interstitial lung disease, Raynaud's myopathy, and arthritis. Inclusion body myositis affects older males greater than 50 years of age. It is a slowly progressive myopathy whereby patients may present with distal or asymmetrical weakness and dysphagia. A diagnosis of idiopathic inflammatory myopathies is reached following a thorough history and clinical examination, as well as relevant investigation findings. Differentials to consider include endocrine myopathies such as thyroid diseases, neuromuscular diseases such as muscular dystrophies, neuromuscular junction disorders, drug causes such as statin, colchicine, hydroxychloroquine, and steroids. Infectious myopathies such as bacteria, viral, parasitic causes. Metabolic myopathies such as glycogen storage diseases, mitochondrial myopathies, other conditions such as rhabdomyolysis, sarcoidosis. Investigations and findings in patients with idiopathic inflammatory myopathies include elevated muscle enzymes such as creatine kinase, aldolase, ALT, AST levels, raised inflammatory markers like erythrocyte sedimentation rate or ESR, C-reactive protein, positive autoantibodies or myositis-specific antibodies such as Jo1, anti-Me2, anti-synthetase, anti-SRP, EMG showing myopathic changes, muscle biopsy showing specific histological findings, and skin biopsy. Malignancy screening should be performed especially in elderly patients with dermatomyositis. In patients with lung involvement, pulmonary function tests should be done. Bohan and Peter diagnostic criteria for idiopathic inflammatory myopathies is as outlined. The goals of treatment are to reduce muscle inflammation with pharmacotherapy and rehabilitation through reduced muscle weakness and atrophy. Pharmacotherapy includes treatment with corticosteroids, hydroxychloroquine, methotrexate, azathioprine, mycophenolate mofetil, rituximab, immunoglobulin or IVIG. Prognosis of idiopathic inflammatory myopathies. Poor prognostic factors include older age of onset, delayed initiation of therapy, presence of concomitant malignancy, pharyngeal dysphagia with aspiration, interstitial lung disease, and cardiomyopathy. In summary, idiopathic inflammatory myopathies are rare autoimmune diseases. They usually present with insidious, symmetric proximal muscle weakness. Whilst there is no cure for myopathies, treatment is most often effective. However, occult malignancy must be considered if presentation is atypical or if patient is resistant to potent treatment. This is the reference list. We have reached the end of our presentation.